Hello and welcome in to another version of our Kettering Health Facebook Live chats, getting real in real time. We do appreciate your time and thank you so much for joining us tonight. Uh, as people are logging in, let's share some kind of details. Maybe this is your first time joining us for our Kettering Health Chats Live. Kind of a cool thing, very interactive, a nice forum for you to feel comfortable there in the comfort of your home or wherever you're viewing us this evening, just to ask questions of our Kettering Health expert. And today's topic is one that unfortunately I have a little bit of experience in. I do have some firsthand knowledge of AFib and kind of when your heart gets out of rhythm, and it's kind of scary, got to be honest with you. We'll talk more about that in a little bit. It can be a very serious situation that requires immediate attention. Sometimes guys get the bravado, ladies too, you get the bravado, you don't, I'll be fine, it'll go away, it's just this, it's just that, it's indigestion. Well, sometimes it's not, and sometimes you need to take it seriously. We're going to give you some of those symptoms that you need to be looking for. So for the next 30 minutes or so, we're going to be talking to our expert on this very important topic. So please weigh in now. If you've got questions about this, maybe you have a family member who has been affected by this. Well, we can arm you with some, we got an arsenal of good information for you tonight to take care of your loved one when it comes to AFib. So please, don't miss a beat. Log in right now. Go ahead, get into the chat box and let us know some of your questions. And so again, the questions via the chat box there is atrial fibrillation, or arrhythmia is another name for it. So chat now. It's like a free consultation with a medical expert, man. This is a great opportunity for you. And if you're just joining us, our topic tonight is AFib. So now let's welcome our Kettering Health expert, Dr. Haseeb Jafri, cardiologist for Kettering Health. Doctor, thanks for being with us tonight. Appreciate your time.
Dan, thanks so much. I'm excited to be here.
Hope you had a good weekend, celebrating and with family and friends and all that. Because I know you have children. So did you make it to the pool or anything this weekend?
Funny story. We don't actually have a pool. I have an inflatable pool that we spend
Perfect.
a lot of time with the kids. It was fun. Yeah.
Well, tell us a little bit about your family and kind of your journey. How did you? I know you're from Lancaster. So how did you land at Kettering Health?
Yeah, great question. I've been a Buckeye through and through my entire life. After graduating from Lancaster High School, which seems like eons ago, I went to Ohio State for undergrad and medical school. Yeah, as I said, 8 years of my funnest part of my life. Then I went to Boston for my residency training in internal medicine. And from there I went to Baltimore and trained in general cardiology as well as electrophysiology at Johns Hopkins. Then I came back to the region because, again, I love Ohio. I love being a Buckeye, so I had to come back.
Oh, man, that's great. That's wonderful to have our homegrown talent stay here in our region and continue to thrive. So congratulations, man. Thank you. I'm glad you chose Dayton, Ohio for a place for you to settle down with your children. How many kids do you have?
I have 3.
Oh my.
Yep.
What are their ages?
9, 8, and 1.
You don't look old enough to have a 9-year-old.
Oh, trust me, I feel old every single day. Absolutely.
Well, at least you're doing something that you love. It's fulfilling.
For sure.
And we were talking about that earlier. Just what does it mean for you to be able to go to Ohio State and then come back to the Dayton region and continue to do what you love?
Oh, for sure. I mean, everybody has had some sort of health ailment, especially unfortunately related to the heart.
Right.
I've not escaped that either with my mom having health issues. So it's one of those things when you can offer comfort and care to a family and do it in the most excellent way and hopefully have a good outcome, then that really means the world. And that's why I do what I do.
Excuse me, are you a Bengals fan?
I was growing up.
From Lancaster?
I'm more of a Ohio State fan. I like the Bengals, but Buckeyes every day.
Well, I just want to congratulate Kettering Health becoming the official healthcare provider of the Cincinnati Bengals. Man, that's a huge deal. Yep. Now, will you be thrust into any situations like that? Or there's a special team dedicated to the Bengals.
Well, I certainly hope nobody on the Bengals has arrhythmia.
Right.
So
some of those games they've had though recently. Cause AFib, not to joke on something very seriously.
For sure.
But 9%, my understanding, 9% of population 65 and older have had AFib. I just want to start on a personal note here, if we could, as people are logging in to share their questions with us. When you lay your head down on your pillow at night and you hear that thump, 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 it's a very peaceful feeling that you don't even think about until you hear your heart going thump, thump, thump. and you know something's not right. That was the first signal for me, my pillow. So let's start right there, Dr. Jafri. What is AFib?
Great question, and thank you for that intro. So, as you said, it's extremely common. Actually, AFib is the most common heart rhythm abnormality in our country as well as the world. It's a disease of aging, as you kind of alluded to. People over 65, there's almost 10% of patients have this arrhythmia. In terms of what actually AFib is, it is an irregular and chaotic heart rhythm, usually quite rapid, that causes patients to feel relatively unwell, and mainly because it produces an ineffective heartbeat.
We have a slide of the heart that we want to show and share with us. What's the trigger?
Sure. So let me actually start by saying, in order to truly understand what is atrial fibrillation, you have to understand what is normal rhythm. In normal rhythm, you have a group of cells called a sinus node in the top right chamber of the heart. That's not what we're looking at here. We'll get to this in a moment.
Okay.
But in the top right chamber of the heart, you have a group of cells called the sinus node that fire 60 to 100 times per minute every minute of your life. That produces a coordinated, oxygenated pump every single minute of your life. And that allows your organs to get blood and allows you to continue to literally go without missing a beat.
Yeah.
Unfortunately, atrial fibrillation disrupts this entire process. So what happens is those cells in the top right chamber, the sinus node, they go to sleep. Then you have groups of cells. If you wouldn't mind pulling up that slide, you have groups of cells.
Slide one, doctor?
Slide one, please.
Okay.
Yep. Slide one, the one previous to this, please. So you have groups of cells in the top left chamber of the heart that start to fire in an irregular and rapid manner, causing that inefficient heartbeat. What we're looking at here is us standing behind a patient or standing behind somebody, looking from the back to the front. You see essentially 4 tubes coming into a structure, and there's muscular fibers around those tubes. Those tubes are called pulmonary veins, or essentially they're the tubes that bring oxygenated blood from the lungs back to the heart. Right where those tubes touch down into the top left chamber of the heart are the areas where AFib cells reside, and this is where the chaos begins.
So the issue is when you're out of rhythm, your blood is pooling, correct? And that can cause clotting, which can throw a stroke type of incident. Is that my understanding?
Yeah, one of the biggest concerns about patients who have atrial fibrillation and why it is so critical to identify it and treat it is exactly what you said. The top chamber starts to beat at 400 to 600 times per minute, and our hearts really can't beat that fast. So what happens is it quivers and the blood pools into the top left chamber of the heart. There's a small cavity called the left atrial appendage, and that's where the majority of blood clots form. And if they're not identified and they're not treated with blood thinners or some other mechanism, which we'll talk about, you can go on and have a stroke.
So what are the triggers that causes this displacement?
Sure. So in terms of triggers for atrial fibrillation in general, you may ask, why do some people get it and why other people don't? The same risk factors that cause coronary artery disease are the same ones that actually lead to atrial fibrillation. When I talk to my patients, I talk to them about risk factors you can control versus risk factors you can't control. So things that you can't control, unfortunately, your age. As you age, the risk for the arrhythmia goes up. Male gender actually has an increased risk of having atrial fibrillation. And finally, genetics. For some reason, some patients have atrial fibrillation that runs through their families. It doesn't do that for everybody, and we really haven't identified why. So understanding those, I think it's critical for us to know the risk factors we can control, because if we can control these things, then we can actually make a lot of headway in the treatment of AFib. And the things that I typically counsel my patients on are obesity, sedentary lifestyle or lack thereof, abstaining from alcohol, and treatment of a condition called sleep apnea, which we'll talk about as well.
Gotcha. Did the pandemic cause more of this? Because, let's be real, more of us were sedentary during the pandemic.
I gotta say, I've seen multitudes more arrhythmias in the pandemic, not only atrial fibrillation, but other arrhythmias. And just to be clear, when we say the word arrhythmia, we mean heart rhythm abnormality. So I've absolutely seen an increase in atrial fibrillation. And that's not just, I mean, I think the sedentary lifestyle adds to it. The other concern is the overall inflammatory state. If somebody gets infected with COVID or any infection, that absolutely increases your risk of having this arrhythmia.
Yeah, unfortunately, I had COVID a couple of weeks ago. I tested positive, and
sorry to hear that.
Well, doggone it, you do everything you can, but you know, you just it happens. So, I guess when I got AFib, the irregular heartbeat was just scared the heck out of me. And I usually kind of blow things off like most people, but I knew, wait a minute, man, it's your heart, dude. You can't mess with that. Plus, I just felt punk. I just felt like I had no energy, and I knew something was wrong. Is that obviously the symptoms that you see most commonly?
Yeah, actually, the most common symptom I see in the majority of my patients, the way you described at the beginning, are those men with bravado that come in and they don't want to describe that there's anything wrong, but they actually have quite a bit of fatigue. And when you really kind of pin them down as to when it started, you know, 3 or 4 months ago, I couldn't mow the lawn, which I could have done a year ago, and something seemed off, and I, you know, attributed that to my age. And I have them pause there for a minute and say, are you sure that over the course of just 1 year, you've aged that much, you can't mow your lawn? So if you can, if there are basic things that you used to be able to do relatively recently that you can't do now, that is something to look out for. The other main symptoms that a lot of patients have are shortness of breath, palpitations, which is that irregular and rapid heartbeat that you have. And sometimes people can get chest pain, but that is less common. So those are the major symptoms patients have when you have atrial fibrillation.
Well, folks, Dr. Jafri would love to answer any questions that you might have. I don't want to hog all this time here. So if you have any questions that you would love to ask the doctor, maybe a loved one was experiencing something a little bit different from what we're sharing with you, please let us know. This is your opportunity to log into that the chat box and just let us know your questions, and I'll relay them to the doctor. Here's the scary part. Can you have AFib and you don't really know it?
Yeah, so there are a sizable minority of patients out there that just don't feel right, and they can't pinpoint it, kind of like we were describing just recently. And they will go about their lives, and things are you know, generally okay, but they don't feel like themselves. And they go for a physical, or they get a basic EKG, and lo and behold, AFib is diagnosed. And again, when you go back and ask them, are you able to ride your bike for 5 miles? And they're like, well, you know, last year I used to be able to ride 50 miles, but now I can barely do 2 miles, and just something seems off. So there are patients, it's not usually that profound, but patients definitely can tell when their symptoms started, especially in retrospect when you describe what's going on. But yeah, you can absolutely have AFib and not know it.
Like going upstairs,
For sure.
You know, 20 stairs that you could bound up with no issue before, now is a struggle. That could be a sign, right,
Absolutely,
Doctor?
absolutely, 100%.
Well, let's pull up slide number 2 if we could, and kind of look at some of the treatment options to continue on, Doctor, with what you can do.
Yeah, I think that's great. So in terms of treatments, when I think about treatments, this is actually a picture of ablation for atrial fibrillation. When I think of treatments, I think of treating 2 separate things. Number 1, the risk for stroke, which we'll get to in a minute. And number 2, the actual treating of the arrhythmia. Initially, we start with medications that help control the heart rate. There are 2 groups that we primarily use called beta blockers and calcium channel blockers. Some medicines you may know are metoprolol and diltiazem, are some very common medications we can use. Now, they do not actually treat the arrhythmia itself, but they help control the rapid heartbeat that comes with AFib. In terms of controlling the rhythm, there's also a group of medications called anti-arrhythmic drugs. And depending on your medical conditions, what other medications you're on, you and your healthcare provider, likely an electrophysiologist or a heart rhythm specialist, can talk about if that is a good option for you. However, the most successful treatment strategy, if you wouldn't mind pulling up slide 2 again, the most successful treatment strategy is a procedure called ablation. So let me briefly describe what an ablation is, and then I'll let you guys see what's going on here on the slide. So an ablation is a procedure where your doctor brings you to the lab. They give you medicines to make you nice and relaxed and asleep. Then he takes a catheter, he or she takes a catheter from the leg. They go up into the top left chamber of the heart, and they either cauterize with a radio frequency catheter, essentially burning away the areas where the AFib signals reside, or they freeze with a cryoballoon catheter. So if you look at the image on the left, you can see that there is a catheter going up first into the top right chamber.
Right.
Just so for your orientation, the right side is actually the left side of the screen, and the left side is the right side of the screen. So this is inverted. You're looking from the front to the back of a patient. So you can see on the left image, you can see that there is a catheter making essentially a figure 8 around the pulmonary veins that we talked about earlier. What we're essentially trying to achieve is we're trying to take those muscular fibers and those areas of pulmonary cells that cause atrial fibrillation and try to electrically disconnect them from your normal conduction system so that you can have a nice normal rhythm without any further interruption from atrial fibrillation.
How do you know which ones to go after?
That's a great question. So if you wouldn't mind pulling up my next slide, I'll show you an example of what we do. So in this slide, I performed a radio frequency ablation. What you can see on the left side, and this is a picture of the top left chamber of the heart. We're standing behind the patient looking through the top left chamber. You can see those 4 tubes coming into that top left chamber. And here we have something called a voltage map. Without getting too technical, essentially it talks about areas that are electrically active versus electrically silent. Red areas are electrically silent, meaning electrical activity is either not there or it cannot penetrate that region. Purple areas are completely electrically active and electricity can flow freely. So we use a multipolar catheter in addition to our ablation catheter. This multipolar electrode catheter can actually make this shell, this real-time map of the patient's heart, to not only make the procedure safer, but more accurate. Essentially, speaking to your point, how do we know where they are?
Yeah.
We can see the signals on our catheter. So when we make that map, we identify where those signals are, and then as you saw on the image on the right that we just looked at, essentially all of those different dots or lesions help disconnect the atrial fibrillation from your normal system. And you can see here, with all those ablation lesions, now that is all electrically inactive or electrically inert, so that your heart can continue to enjoy normal sinus rhythm without being impeded by atrial fibrillation.
That is amazing. The quality of that slide just shows you the quality of care that Kettering Health has. I mean, that makes your job, there's no guessing. I mean, you know exactly the affected areas and how effective you are being in attacking them or cauterizing, whatever. Now, I had the cardio conversion twice, unfortunately, and it worked twice, fortunately. So is that common as well, or pretty much the same as what you're talking about?
So yeah, so you'll definitely have a lot of patients that come either to the emergency room or to the physician office, and they'll say, I just don't feel right, my heart is racing. You'll get an EKG, and yeah, you have atrial fibrillation. After we make sure that it is safe from a stroke perspective, we can do a procedure called a cardioversion or a shock. Essentially, that is where they give you some light sedatives, make you essentially go to twilight, and then they tell the AFib signals to be quiet by shocking your heart and tell your normal rhythm to start picking back up. That is quite common initially prior to actually developing a treatment strategy for AFib. Sometimes patients may need that down the road for they've had an ablation or they're on medicines and they have breakthrough episodes of AFib. And while we're still working on risk factors or potentially talking about medications or repeat ablation, that can be utilized, but that's less common.
That is less common, okay. We've only got about 9 minutes to go here, so if you have any questions, please in the chat box, let us know your questions here before we sign off. Let me ask you, doctor, if you have AFib, does that mean you have to take medication for the rest of your life?
So great question. It depends on your risk factors. When you see your physician, they'll tabulate your risk for stroke by essentially going through your risk factors. If you have, say, coronary artery disease, history of stroke, heart failure, they tabulate each one of those for individual patients. And if your risk factors are sufficiently high enough that your risk for stroke is higher than the general population, then we generally recommend some sort of treatment to prevent stroke. And these could include medications called blood thinners. And the common ones are warfarin, Eliquis, Pradaxa, and Xarelto. And based on what your prescriber and you choose, you are able to take those medications. Now, some people can't take blood thinners for various reasons. So say they've had they've had bleeding in their cranium, or they've had GI bleeding, or so on, and
Sure.
they just can't take it, or high-risk professions.
Mhm.
So either way, there are other treatment options. If you wouldn't mind pulling up slide 4, there is a procedure called a Watchman procedure, and that's where we actually go into that top left chamber of the heart, where you can see right here. It's a little dog-eared structure, this appendage that sits off of this top left chamber, that where 90% of the blood clots form. And so the Watchman is a quarter-sized device that your physician can go, your electrophysiologist can go into this top left chamber, close and seal that area off, and while your own body forms tissue on top of this Watchman device, over the course of 6 months, you continue your blood thinner, then you're eventually able to come off, and your risk for stroke without taking medications is essentially that of the normal population.
Mm-hmm.
So again, do I have to take medications for AFib? In terms of the stroke aspect, either you take blood thinners for the rest of your life, or if you can't, then this is an option.
Interesting.
In terms of the treatment of the rhythm, sometimes patients do have to take medicine to slow their heart rate down, or if you choose with your physician to go on antiarrhythmic drugs, or drugs that keep you in rhythm, then yeah, you can decide to do that. But it's not a definite, but a lot of patients do take medicines long term.
So you don't have to have a medical procedure.
You don't, but I will
Okay.
tell you the data is very clear that once you identify atrial fibrillation,
Right.
and the sooner in your time course where you and your physician talk about risk factor
Right.
control, and then also doing a safe and thorough ablation, those patients absolutely do better in terms of having less AFib in the future,
Right.
and having enjoying normal rhythm for the rest of your life.
Well, give me a timeline of from the time that you notice that you're having arrhythmia to the time that you see your doctor to the time that you can get treated. What does that timeline look like?
Yeah, so if you are actually diagnosed with atrial fibrillation and you are started on blood thinners, and then you see a heart rhythm specialist, honestly, if you've had just one episode and it's been in relation to, say, a surgery or an infection or something else, then you can always be judicious about when to start. But if you have, the general timeline of AFib is that you may have one episode that you feel,
Mhm.
and months may go by or even a year may go by. You may not have another episode, but over time it becomes more frequent and actually less symptomatic. And you can get to the point where if you ignore it, you can be in AFib all the time. Unfortunately, at that point, we absolutely can treat patients, but it's a lot harder.
Yeah.
So what we recommend is usually if you've had one or two episodes and they've been quite traumatic and there's been no real trigger that we can identify, obviously risk factors aside in terms of obesity, lack of exercise, alcohol intake, we would recommend treatment with either ablation or antiarrhythmic drugs.
So can you ever say that if you have had AFib that you're ever really cured?
Great question. I caution patients on
Right.
saying that there's a cure for AFib. It's a menace of a disease, if you will. In order to truly get as close to a cure as possible, I tell my patients that I have to first do either a safe and thorough ablation or have a safe and aggressive strategy with antiarrhythmic drugs to control the rhythm. But equally as important, I think the most important thing a patient can do is really adhere to the risk factors. So let's talk about that for a minute.
Sure.
In terms of risk factors, if you are overweight or above your ideal body weight, the studies are clear. If you can lose 3 to 10% of your body weight and get closer to your ideal body weight, you will do markedly better. And the closer you are to your ideal body weight, the better you'll do.
Mm-hmm.
So that's number one. Number two, physical fitness. Aside from the actual weight issue, the more physically fit you are, the more cardiovascularly conditioned you are, the better you will do. So patients ask, well, I can't walk because I've had knee surgery or hip surgery.
Right.
Do anything you can do.
Right.
Walk, ride a recumbent bike, swim, anything that's going to provide moderately intense aerobic activity. And what I mean by that is, essentially, if you're out and you're walking with somebody or working with somebody, you're not so short of breath that you're huffing and puffing, but you're not just having a casual conversation, you're actually working. So as long as you and your doctor deem that it's safe to exercise, you absolutely should. I tell my patients to honestly walk 30 minutes every single day.
Sure.
That's what I tell my patients.
Yeah.
In addition to the physical fitness and obesity, alcohol unfortunately increases your risk for AFib. And the data here is also clear. My patients don't like to hear this, that the correct answer is as close to zero as possible.
Okay.
If you drink alcohol, it does increase your risk. And reducing that risk, if you really
Markedly, slightly,
pretty substantially.
Oh, okay. Well, it's not worth it, the drink's not worth your heart, that's for sure.
And the last, and actually almost as important, is sleep apnea. Sleep apnea is a condition where when you're sleeping, your airway can intermittently close off, essentially obstructing your airway. If you have this, it's really critical to get treated. So I can go in and do the world's best ablation. We can do everything else right, but if you have sleep apnea that is not treated, you will get AFib again. So to answer your original question, can we have a cure for AFib? The answer is, if we really work hard on my part, and I work really hard on your part, and you work really hard on your part, together we can get as close to a cure as possible.
Right. Well, listen, we've got just a couple of minutes, Doctor. I wanted to ask you about the AFib clinic.
Yeah.
Can you give me details of that, please?
Yeah, Kettering is developing a state-of-the-art clinic right here in Kettering, Ohio. There's only a handful of these throughout the country. And the entire impetus of this is to allow our established patients as well as new patients to have a venue where, if you're clinically stable, you can get in with a physician or a nurse practitioner or a physician assistant within 48 to 72 hours. So we will follow our chronic patients in terms of their medicine, their symptoms in this clinic, but also if you are new in the region and you just don't know what to do, we should have one phone number that you'll be calling through Kettering and be directed to the AFib clinic. Additionally, if you're a provider in the area, if you're an emergency room physician or a PCP who just needs help with your patients in terms of taking care of AFib, give us a call. We'll be able to get them in, get a care plan established, and get them taken care of.
Fantastic. Dr. Jafri, thank you for your time this evening and all the great information that you've shared. Is there anything else on a personal level that you'd like to share with us about this topic?
Yeah, atrial fibrillation is extremely common. It's not going away anytime soon, unfortunately. One of the most profound things I've heard about AFib, if you really want to help prevent this from happening or try to maintain normal rhythm, the best thing you could do is put on a pair of tennis shoes, get out, be physically active. Honestly, the more physically active you are, the better shape you're in, the better you take care of yourself, the less likely you're going to need to see me.
Seems like every Kettering Health expert we have, it all boils down to you gotta put yourself first. You know?
100%.
And if you've got kids like you do, Doctor, it's easy to kind of get active and stay, keeping up with them. But if not, this is something over 60 that we have to be concerned with. And sometimes it's tough to get out and push it out the door, but we hope that you will. Hey, we've got more for you, Dr. Jafri. Thank you so much for your time. We really appreciate it and your service to our community. Thank you. Look for updates of what's coming up in June. We'll have that for you. And if you'd like more information, we urge you to go to ketteringhealth.org/healthcare for more great information from Dr. Jafri and his team. Well, I'm Dan Edwards. Thank you for joining us for this Kettering Health Chats Live, our great conversation today with Dr. Jafri. On behalf of all of us, we hope you have a safe, happy, and healthy summer, and we'll see you in June for our next Kettering Health Chats Live. Kettering Health, be your best.